Hi, everybody. Today is December 22, 2021, and this is a special episode of Coronavirus Conversation. I'm honored to have with me Dr. Nathi Mdladla from Johannesburg, South Africa. And he is an anesthesiologist working in the ICU and with cardiac care. But I'll let him introduce himself and probably redo his name insofar as I might not have gotten it quite perfectly. So here we go, Nathi.
Thanks, Randall, and good day, everyone. My name is Dr. Nathi Mdladla. I'm a cardiac anesthesiologist and also an intensivist in Johannesburg, South Africa. I'm a former head of ICU at one of our academic hospitals up here in Johannesburg called George Mukari, it's Fako Mahato University. And I'm involved as well in private practice, although peripherally with the management of our COVID sort of ICU patients. In our hospital previously, I managed our 280-bed COVID ICU facility, which at peak in the third wave or the Delta wave, we had 180 total admitted patients with COVID and about 60 to 70 PUIs at any given day at peak. Total numbers that we had for Delta was 810 between the time that we declared Delta wave, which was our third wave, and the end of that wave. I'm out of that hospital now, but I still see their stats. I left the end of August. Once the third wave was over, I left the hospital. But I still see there are waves in this fourth wave now with, hopefully, or we think that the majority of cases are Omicron based on the sequencing data that we have available. They have peaked in Omicron at the hospital at 160 positives that were admitted with about 70 odd PUIs. But interestingly, most of the positives have been actually incidental findings. So as of this morning, they had 16 patients on any form of oxygen, so nasal cannula, face mask, only one ventilated. Actually, but the ventilated patient, interestingly enough, is a neurosurgical patient with a brain tumor. So the reason it's ventilated is not because of COVID, it's actually a coincidental COVID finding with a brain tumor, and that's why the patient is actually ventilated. It's a young patient, but they're not actually heavily or on high oxygen. It's not for COVID that they're ventilated. Of the 16, they had 13 that were on nasal cannula, 2 on high flow, and 1 that was on NIV, which is CPAP. And that is out of 155 admitted patients. So it's almost a 10% on oxygen patients. And within those as well, a few of them are actually in the hospital for something else. And the COVID is kind of incidental. In the private practice, which is where I am now, the private hospital that I'm at, it's one of the biggest private hospitals in Joburg, and it was a major hospital that admits COVID in the last 3 waves. We have ECMO capabilities here as a last resort. And at peak, we ran close to about 20 ECMOs on patients here. At the moment, from the stats that I saw yesterday, I think they had 5 ventilated patients. About 3 of them actually were quite elderly, with comorbidities, elderly as in over 80s, significant comorbidities. We had been keeping stats for vaccinations and against vaccinations, but over the last 3 weeks, they've actually stopped putting them up. So I can't actually tell you what's going on now in terms of vaccination status. But to note is that South Africa in general is still less than 30% vaccinated, 70% unvaccinated. And it tends to go with the economic status as well. So the more well-off and educated people are probably much more vaccinated. So in private practice, you'll have probably a higher proportion of vaccinated patients compared to the state sector. I know actually the state hospital, my private hospital, they show the numbers. So the numbers were actually close to what you would see with that type of population in the state hospital, to be mainly people that cannot afford private healthcare, who actually then go to the university hospital. So the numbers there are more unvaccinated than vaccinated. I think they had, of the 155, I think there were about 18 vaccinated patients that were in. And obviously the rest are unvaccinated. But like I said, of the sick patients, it was actually just under 10% of that number, around about 10%. So yeah, so the status here, we are in the 6th week now of what we think obviously started 6 weeks ago as Omicron, which in terms of analyzing it, it coincidentally also came up as we were starting to encourage people to do boosters, those who were vaccinated, and when we were also encouraging people that are not vaccinated to actually start considering vaccinating. Our scientists had predicted, or were expecting this fourth wave to start around about the 2nd of December, and the information that we started getting out about 8 weeks before, and lo and behold, towards sort of end of November, we started seeing some cases. We actually past peak now. It's clearly past peak. The highest numbers that we had, if you look at 7-day average numbers, probably just around 23,000, 24,000 daily cases. So we have a population of 60 million people in this country. So you can sort of compare it to the US in terms of those numbers. At the moment, the last numbers, yesterday's numbers was about 15,000. Today, I saw that sort of, say it's gone up to 19,000, but our stats are really not daily stats. They're probably tracking by about 3 to 4 days, to be honest, although we put them up as daily stats. The 7-day average is probably more accurate, and I think that's sitting at around probably 11, 12,000 at the moment. So we definitely past peak. Johannesburg is where the first week, which is where I am now, we peaked first. We actually had the highest numbers at some point. As we peaked at about 12, 13,000 daily cases. And today we were at around 3,000, I think, cases. So we've definitely peaked. Cape Town has gone up a bit higher, but also Cape Town is kind of our major festive season destination. So a lot of Joburg people have probably gone there. But they've just peaked after us. They were at 15,000, I think yesterday or today.
So Nathi, can I ask you a couple questions?
Yeah.
I'm going to maybe backtrack, and maybe for some of our audience who don't understand what PUI is and ETHMO, maybe you could just define those. But before I let you go and do that, my other question is the character of the Omicron wave different from the previous ones?
It's definitely different. The rise was very rapid. Within, I think we actually had a graph that I showed yesterday that we were going to show. The rate of rise compared to even Delta has been very steep, as you can see there. The characteristics of Delta for us, it was a bit broader in terms of duration. So it ended up having a lot more cases than Beta, for example, which is the wave before. And if you look at this Omicron wave now, I mean, it's a steep rise. Within 2 weeks, we're actually probably at our highest numbers. And the drop as well has been just as rapid. But of interest, if you look at sort of the orange-yellow, which has been superimposed on that graph, which is actually the deaths, daily deaths, or average over 7 days, one can see that for Omicron, it just stayed flat. It's a similar thing that we're seeing in the hospital settings. First of all, admitted case numbers are very low for most places, especially the sick patients are way lower than we actually had with Delta. Mortality rates have actually stayed in sort of double digits. I think we've touched sort of 100, but when you get up to 100 on a day, it's because also some numbers are missing over the weekend. So we have a day where there's 3 deaths a day, then you have a day where there is 30, and then we had one day where there's 100. We're not sequencing every, unfortunately, death case, So we do not know whether all those cases are actually Omicron or not, or some remnants of Delta. There's definitely going to be a mixture of the two. But yeah, they've stayed in terms of 7-day average. We've stayed even below the interwave numbers between Delta and this wave in terms of the total deaths per day.
Mm-hmm. Yeah, just I have the worldometer stats for South Africa, and you can see the cases. My big issue is that we are misinterpreting the problem. We keep thinking about cases, positive test. We're not really thinking about the damage. So here are the various waves. I think this is, I don't know if this is ancestral version or this is maybe beta, and this is delta, and this would be Omicron over here. You can see that their active cases go up and down, but the deaths over here, it's kind of no pun intended, flatline. So it's not really mounted. This is not this is not the Black Death over here. It's not the bubonic plague. We are right over here. So if you apply the averaging line, such as you're saying, you'll see that this is not a wave that coincides with this wave of cases. So if you put the same line here, you can see that the lines go up for cases. So if we just really focus on this piece over here, this is now, we see that the cases have gone up, and then it'd be hard to superimpose it precisely, but the deaths have not changed, and then this is the actual number per day over here. So we're down over here. We're talking about a country of, what did you say? How many tens of millions? 60 million? And you're talking about 33 moving average, about 33 deaths in the country from Omicron. So that every people die, people are born, people are die. So in a nation of 60 million people, I forget what the number is. It's going to be 18,000 deaths a day or something like that. Anyway, I might have my number wrong. I apologize, but this is a very minuscule percentage of the overall deaths in general. It seems to be currently.
Definitely.
Yeah.
And the one thing as well, compared to what we saw in sort of beta and delta, beta in our hospital, we actually had way more sort of mid-40s people compared to the alpha variant sort of passing away in the ICU. In the private sector, it was actually delta that had the highest number of sort of the youngish population. So it's sort of different waves between the different population. I think it's based mainly on how also people have been isolating. In the alpha wave or the first wave, the poorer communities didn't actually, because they can't actually isolate, they can't social distance, they can't avoid overcrowding. So they were actually maximally exposed in the first wave. And in beta and delta, sort of mainly beta, we saw a few more younger people, but in delta, it again sort of balanced out. But the private sector, which is where people are getting more exposed in delta, they had more sort of younger population who have been sort of working at home, right. Coming out in delta and getting exposed. So they had actually a much more significant wave.
We had a very similar thing. I'm just going to put up this little covariant pictogram. I'm kind of fond. This is a difficult slide for maybe some people in the audience to understand, but I'm kind of fond of it. By color, you see the various, I guess mostly Greek letter here, and this here South Africa and the USA, for instance. This greenish color over here is delta. So we pretty much were doing a delta wave. This is not quite fully up to date. This is in the beginning of December. You can see Omicron kind of shouldering, nudging its way in here and becoming the predominant strain in South Africa. And likely we will see this as a following wave. But I do think that this is a very different situation from the other ones. I think the ancestral version, which doesn't have a Greek letter, the original COVID, SARS from China, 2019, had a higher case fatality rate, partly because we didn't notice that many. We had to, we didn't have that much testing. So a case was somebody who showed up at the hospital. That's what I consider the classic definition of a case, somebody who's actually ill. we've redefined cases to be somebody who has a positive test. So now we're really, great at testing, so we can find these minor distinctions, genomically, and call this one whatever Greek letter we decide to. In this case, Omicron. It could have been Chi or Nu or whatever. But in point of fact, it seems to me that this Omicron is attenuating down to something closer to just a common cold. I don't know if that's correct or not.
No, I agree with you. I think it's definitely correct. It's sort of a balance between both of probably much higher testing, better treatment, I think, or hope, but definitely less virulence as well. I mean, the majority of people that I'm seeing, I'm actually treating around about, I think I'm at 37 people outpatient now. In general, actually almost everybody that I'm actually handling at the moment. They have maybe 1 or 2 days of like very bad flu, made worse just by the fear of COVID itself. But they get through sort of second, third day, and they're actually better and feeling okay. And by the sort of fourth day, they off most meds that we put them on, or just decongestant. So typical symptoms, just headache, stuffy nose, runny nose eventually. Funny enough, anosmia is never really complete. So they lose smell and taste, but it's sort of never complete like it happened with the ancestral virus.
Yep.
And tends to recover within 2 or 3 days. And the fever is like worse. It does get hectic for about 2 days, where people that know malaria, they actually think that they actually have malaria. And then it sort of settles with just antipyretics or whatever agents that you use for them. Very patients have gone as far as putting them on steroids at home because they're never sick enough to go in. But when they're getting tired, often steroids seem to help. And then inhalants at home. 2 patients have dropped sats to around 88 at home, but recovered within a few days on that. So nobody's had to go to hospital yet, and we manage everybody at home.
Okay, so as far as the situation in South Africa on the ground, the way that people are looking at it, are they taking, first of all, they're taking any prophylactic treatment, any medical treatment during the episode? Is it just palliative care? Are there prescribed medications, or do people purchase them? And any thoughts about whether any of these things work?
So I think we're like the rest of the world. Here, at-home treatments or out-of-hospital treatments haven't really been encouraged by the government. So there's no structured out-of-hospital treatment protocols. But I'm part of groups that actually do that. I've been treating patients out of hospital since the beta wave. That's where we started, so December, January this year. But I treated more during Delta and a few more now. I got to about 300 and something patients during Delta that I was treating at home. Because most patients cannot afford to buy medication from pharmacy. So I haven't really treated many people who do not have either medical aid or medical insurance or can buy meds themselves, except when I was still in the state hospitals. In the state hospital, we managed to get some therapeutics that sort of deemed controversial. So we treated a lot of patients in our hospital during the third wave. But out of hospital, most of my patients are actually working people who can actually buy medication from pharmacy. Very few people are not on insurance that can actually buy for themselves. So there's a group of treating physicians that we have here that amongst us we manage actually a lot of patients. But to be honest, it's actually not a formalized process. And we've had lots of pushback from the insurers, from our indemnity companies, and eventually some of the societies, medical societies, who've declared that they're not in support of outpatient treatment. But amazingly, most of us actually treat outpatient, hardly have anybody going to hospital. So we just don't understand what's up with that.
Yeah, that is an interesting question. I just never really have quite figured out, why everyone has to be. I understand. I am pro-vaccine. I love vaccines. I've taken a flu shot every single year since medical school, and for other occasions, I've recommended vaccines. I've given out literally tens of thousands, well, thousands, probably into the low tens of thousands of vaccines over my life. And I think they're, interesting concept, and they go back hundreds of years. George Washington's army, had a very primitive version of smallpox vaccination from person to person in order for so that our country in part is founded on the concept of vaccination. So I love vaccines, but I don't see them as the only tool. If we were still waiting for a vaccine for HIV, people would be dying, like crazy from HIV. So if you were just, when Zika came around, everyone said that nobody should have children. I mean, there were various health ministers in Latin America who said nobody should have kids until we, fix Zika by a vaccine. Well, it's 6 years later, and there's no vaccine for Zika. There might be, mind you, someday, but people can't put their lives on hold waiting for a vaccine, especially the first year, which I don't think was, quite. I think it was a little bit phased in late in South Africa. Based on distance and climate and whatnot, but when there was no vaccine, it seems like treatment's a reasonable approach. I mean, it certainly has worked for HIV, and again, nobody's waiting for an HIV vaccine anymore at all. But I can't quite figure out why, if you have two tools, if one is going to be down the road, tomorrow, why you shouldn't start working today with the tool you have. And even when the next one gets there, why you can't necessarily work them together.
I mean, exactly. And even in December last year, I remember I had been in a group with our Minister of Health and some members of our Ministerial Advisory Committee while we were waiting for vaccines. I actually said exactly that. I actually said, not knowing how the vaccine was going to work, we shouldn't give up on therapeutics. So I actually pulled from December last year, especially because beta was actually quite bad. And I actually advised and spoke to our sort of government and said, let us work on both so that the people that either cannot take vaccines, either reactions to vaccines, or where vaccines actually fail them, because we knew that the vaccine is not going to be 100% effective. So wherever it fails, there should be a therapeutic option. And at some point, while we're perfecting the vaccine, if you have effective working therapeutics, you can at least buy that time by saving a lot more patients until we also get to a stage where the effective vaccines. And I'm like you as well. I mean, I've taken all my vaccines. Just before, when COVID started, before it actually arrived in South Africa, I made sure that I took my flu jab just so that actually I wouldn't confuse the two, or at least make sure that I don't get both sort of influenza and COVID at the same time. And I'm pro-vaccine, like everybody else. But the role of therapeutics cannot be downplayed. And I saw this firsthand within beta. And that's when I started using, the first wave, I didn't use any therapeutics in the first wave, not even hydroxychloroquine, because we had such a mild first wave. But the second wave really got me desperate. And by the time Delta came, the rest of the country, people actually had a hectic Delta. We were the only university hospital that actually used ivermectin mainly with colchicine and other agents, antihistamines, and so on and so forth. We had one of the mildest waves compared to most hospitals. Our mortality numbers are actually way less than the beta, which we had 610 admitted patients in beta, and we had 805 admitted in delta. The rest of the country, where everybody was spinning around and nobody was actually using what we were using. So for me, in both in-hospital setting in ICU and out of hospital, as I said earlier on, none of my out-of-hospital patients, more than 300 that I treated then, I'm not a GP, but people just contacted me to help them. I didn't even charge them or anything. I treated everybody, I treated for free, but kept in touch with them and follow them up until I would say to them, I'm discharging you now. And not a single hospital admission of those patients. People had probably periods of dropping sats quite low, two of them at home. So Omicron has been the same. But with Omicron, I'm not even pushing using things like ivermectin. I think people want to. I script it, and I say to them, if you want to use it, it might just shorten your disease. But Omicron has been so mild that I'm actually not, compared to Delta. Delta, I really would push hard. High doses get up to even 10 days for some people. With Omicron, within 3 to 5 days, most of them call me back and say, oh, I'm fine now. Actually started doing my usual stuff of I'm back either at work or I'm moving around, I'm playing golf, I'm doing this and that. So I haven't even been pushing sort of the more intense anti-inflammatories just
Yeah,
because it's
so
so
right.
mild.
So that's an interesting point. You know, I came up with this originally, but certainly other people have came up with the same idea, that Omicron might be the best vaccine. That
Yep.
if you had to choose between the profile of the vaccine, which is a single spike protein, actually from the ancestral version, it's not even from this current version. So you're picking a vaccine that is, 7 or 8 strains ago. Basically it's last year's coronavirus. And if we gave out last year's flu shot for this year's flu, that in a sense would be medical malpractice. I would not be able to give out last year's flu shot unless I had huge disclaimers about, like, no way I could find this year's. Anyway, so we're giving the ancestral vaccine for a single spike protein. Conversely, somebody theoretically could have Omicron and the equivalent of a cough or whatever, but have, a full, basically natural immunity to 27 times more of the, virus's proteins, and mind you, up to date, and for the ones that are out there now, and whatever Greek letter comes afterwards, you'd be much closer to it than you were from, the one a year or 2 years ago, it seems to me.
Definitely. And for us, again, probably my sample is probably a skewed sample. Out of sort of my more than 35 patients I'm treating at the moment, the interesting thing is that only 2 are actually completely unvaccinated. The rest either just received their boosters or they just caught up with their second dose recently. And that's sort of the general sort of picture that a lot of people are actually seeing in the outpatient setting. Interestingly, so again, I think that might be skewed just because I'm dealing with people that can actually afford, who would have been maybe most likely to vaccinate. But of those people, I think I have one person that actually has had COVID before, and that person was exposed in August last year, so that was the first wave. The rest of the ones that actually have is people that they've never had COVID ever, and actually getting it for the first time, but vaccinated and getting whatever they're getting now. And thank God, as you say, I think as well is probably our early Christmas gift that we actually received.
Yeah. No, that's interesting. It's
and
a
most
silver
people that I
lining.
speak to is, if you're going to be exposed to anything, it's probably it if you are low risk.
Yeah.
And you're going to get hopefully more robust immunity that's going to last you longer. Until we actually probably catch up with our vaccines for the new strains. For my practice, actually, it's been interesting because I've been asking everybody. And in our hospital, I've actually asked them as well to actually ask patients if they've been exposed before. Interestingly, in this private hospital I'm at, we haven't had an admission yet of somebody that's had COVID before. I'm not saying it's not happening. I'm hearing from friends and people outside
Right. So that's an interesting point.
So been exposed before who had it. And one of our insurers released stats recently, and they reckon that if you had Delta, you probably 70% less chance of getting Omicron. If you had Beta, I think they put it close to about 50, 60%. And then if you had the ancestral strain, you at about 30% protected for Omicron. I think those are the numbers at the moment.
Yeah. Absolutely right. You and I are in reasonable agreement about all of this stuff. I just had a quick question going back to this chart here. We were all in an uproar, I guess, last summer or so over Delta strain, and I don't have the India chart up, but basically in India, Delta was just the Indian strain, and people had it. And then it went away. So these graphs go up and then they go down like a roller coaster. So it goes up and goes down. At this point in India, there was very, very low, maybe 10, 15% percentage vaccinated at the time of their so-called Delta strain, which is the India strain. And when you had Delta here, what percentage of the population was vaccinated at that time? And why do you think it went up and went down again? Was it public health measures? Was it immunity? Was it the disease running its course? I wonder if you have any thoughts about that.
So it's actually interesting, that graph. If you can put it up again. just so that I can talk to it. So our vaccination started at about where your arrow is, but on the upstroke of Delta. And that is when we were vaccinating the elderly people, so a bit further up, sort of on the upstroke of the Delta wave. That's when we actually started vaccinating. And we started the elderly, and by the time we got to peak of Delta, we were still probably around about 10, 15% vaccinated by the time we got to the peak of Delta.
Right.
Now, I actually wrote about this for us because if you look there's that inter sort of wave peak again within the Delta wave. There's sort of a blimp there, yes, there. So that sort of coincides, interestingly, with about 2 weeks to 3 weeks after we started the vaccinations for during Delta. So now, within that, if you spoke to people, especially around, like I said, we started with the elderly. A lot of the elderly that, or a significant number, actually ended up treating a few patients who were either vaccinated 2 weeks prior or 3 weeks prior to this, who suddenly were presenting with COVID. Some of them, like within actually sort of the 2 week period. And that spike that we have there, I actually wrote to our community here, and I actually sort of called it sort of a spike protein disease. It's a presentation I did during Delta. And I said, I actually think it's like a spike protein disease because at this stage we were using mainly Pfizer as a vaccine. So it's a very odd blimp that I actually saw there. And I wondered if it wasn't that. And as I said earlier on, if you look at this Omicron wave, Omicron actually coincided where, again, we were either doing boosters for healthcare workers and we were doing second doses for the young people that hadn't been vaccinated, and then boosters in general for people who were beyond sort of 4-6 weeks of whatever Pfizer vaccine that they actually had. And it's been interesting to me to notice that, I mean, even within the private hospitals where I am now, they have about 75% vaccinated healthcare workers here, with about 25% who do not want to vaccinate. At the peak of Omicron, sort of around about 2 weeks ago, we had in this hospital almost 200 staff who were actually positive. And most of them were very close to about 2 weeks or so after their booster doses. So for me, that coincidence has been very interesting. I ended up actually saying to some of the staff members that probably need to wait until about January, once the wave is fully down, if they want to actually boost again, the ones that haven't, or to get their second doses, the ones that actually haven't. I think there's actually a link between the two. It's an uncomfortable thing to say, I know, but that's the observation. I think what you observe is what you observe.
Could you tell me, just describe that link again, please?
So describe that.
Tell me, you say, I think there's a link between what and what?
So I think there's a link because it sort of coincided. So three things happened. So we pushed very hard to get boosters done for people that were sort of 6 months and beyond for Pfizer. And then people that were due the second doses, there was a big push. And then people that were supposed to be first time vaccinated, because we're anticipating sort of Omicron. That was the going discussion just before Omicron hit. So if you look at our vaccination numbers, which I don't have here, I'm not sure if you've got them on your screen, you'll notice that our significant push for vaccines started sort of mid-November, sort of early to mid-November. And around about 2 weeks beyond that, this is also like around about when we actually started seeing the spike in Omicron. So when I'm looking at the healthcare workers, so J&J was our main vaccine for healthcare workers in February, March. So when there was a recommendation that the J&J vaccine booster should be done beyond 8 months for South Africa, a lot of the healthcare workers started boosting in October, the ones who did their first doses in February. Some people were later and actually started doing their boosters in November. Within the people I actually work with, I know a lot of people started doing their boosters beginning to mid-November. and a few of the staff actually that I've been working with. As I say, for this hospital, we probably picked at about 200 staff that actually were positive, and the majority of them was actually following either an mRNA booster to J&J. Some people prefer to do that, or others took a second J&J booster for the original.
All right. Well, I'm trying to get up the data for South Africa on immunizations. I'm having a little bit of, distraction trouble. I don't think I can do it quite off the bat for us right now. So I'm going to stop that.
Yeah. But anyway, yeah, we had probably one of our big sort of spikes in boosting about 6 weeks ago.
All right, I did want to make one correction to myself, because these dates here on the bottom, if you look at if you pause the slide and expand it when you're watching, these are in the non-US formulation of date.
Yeah.
So I said January over here because it said started 01, but the months are in the middle. So this is September 2020. You had your ancestral version peak in January. Excuse me, in December, January.
Now our ancestral was June, July last year.
Well, here it says 12/20/20, and then Delta is
that was beta.
Oh, I'm sorry. So which is which here?
So the graph that we have there does not have the ancestral wave.
Oh, I see. It's prior. Okay,
yeah.
my mistake. So this is which version? This is beta, and this is Delta, and that's Omicron. Fair enough. Okay, my error. I don't think I had it on the stream here. So just to clarify, these dates in the middle are the months. So that's September 2020. This is January 2021.
Yeah.
And this is
that's beta,
and this is Delta, Omicron. And then if we go back to the other chart, I'll remove this, but at any rate, we can see the three peaks from the South Africa strain. So you've been very informative. What's the take-home message for people watching this? What do you think?
So, I mean, we've been trying sort of to share this with everybody. We've also spoken to some people in the UK, is that, first of all, Omicron definitely is a milder virus in the majority of patients. Probably a few days of really bad flu-like symptoms, very manageable with sort of typical flu meds that people usually take at home for regular flus. Without needing to actually get admitted. If one were to be exposed to anything, that is coronavirus or COVID-19, this is probably the virus too. Mortalities are really minimal. And in most hospitals, if they actually do declare who actually has died, it's been the very elderly, significant comorbidities, or patients who have something else. Most of the findings have been incidental in the hospital settings. So it is not something, even in my opinion, I agree, to actually be panicking about. Unfortunately, because it's highly contagious, the numbers are going to be high as you test much more and more aggressively. Interestingly, our government now has actually advised that people who are not sick should not actually be tested anymore. Just because we're having so many incidental findings, which we then call in COVID-19. And if one thinks that COVID-19 is supposed to be a syndrome of somebody who's sick with a positive swab, at the moment we actually have more cases, kind of the typical case-endemic situation, positive cases who are actually not sick, which skews the numbers. If you actually looked at sick people with a positive swab, those are actually a fraction of the cases that we actually have at the moment. So it's definitely not something to be panicking about, and I don't think it's something that government should be pushing. In my opinion, and I've been giving this advice, is that if you vaccinate in the middle of the peak, where we know that people actually reduce their immunity, you're highly and most likely going to have more positives, or people actually just then get a flu-like illness from corona, which is then circulating in the community. And that spikes your numbers. And I think that's what we're seeing in the UK. If you look at the UK, they have the highest peak at the moment compared to any of the previous waves. And what they're doing right now is that they're aggressively boosting in the middle of the wave, with high circulating probably COVID and reducing population immunities for at least we know now, or there's a suspicion in certain quarters, and I belong with those people, that there's actually a reduction in immunity for about 2 weeks post vaccine, whether it's a booster or whatever. And at that stage, you're actually highly exposed. And if you meet somebody who actually has COVID in a wave, then actually you're going to get it as well. And I think that's what we're seeing all over. And I think the UK, the numbers might actually go even higher and higher because they're actually doing exactly that. They're boosting in the middle of circulating virus, and they're negatively affecting the immunity, and they will get positive people or recently boosted people who are going to get COVID. And I think that's happening all over the world as people are panicking. So I don't think it's time to panic. People should just either get exposed, get sort of proper immunity to that, and then we'll see past that wave. It's definitely not going to hamstring or overwhelm any healthcare facilities. We definitely not overwhelmed. In Joburg, as we pass peak, in this hospital where I'm at now, at peak, I think we had probably 6 to 7 ICUs are running COVID. At the moment, we have 1 ICU, and it's got 13 patients in it. That's all. We have a total of, I think today we had a total of 28 or 27 patients. 14 of those are in the normal ward. They're not even on oxygen. And 13 are in ICU. And of those that are in ICU, I think about probably 11 or 10 are on just nasal cannulae, oxygen, few ventilated, 1 or 2 that are ventilated. So it's definitely, compared to where we were in Delta, it's, I know, 10th, if not more, reduction in sort of significance or severity.
I think that's an amazing and important message. I'm just going to just corroborate some of the things you said here very briefly. This is the UK, United Kingdom, high number of cases. If this looks familiar, it's because it is. Active cases went up. Deaths, again, no pun intended, flatlined. And you can see pretty much as in South Africa, the number of fatalities are very low. I always think, as you've very accurately pointed out, that a lot of people are dying, not necessarily from, but with COVID. And so, and just to clarify your earlier point, here is the ancestral version at South Africa. So you actually literally had 4 waves, as it were. This is from July 2020. January 2021 was beta. Delta is over here in the summer. And here we're having Omicron. Over time, one of my little, I don't know if this is what I think is the case. The more severe viruses that we get have kind of an offloaded, like a summer home, of some kind of host animal reservoir. So the influenza we get yearly packs a little bit more punch because it's not in humans. It's not passing around between people. It's passing around between, farm animals in China someplace, and they bring them in the house in the winter because they're small farms, and then they, sneeze on each other, whatever, and then the humans bring themselves to market, and then we have the Shanghai flu, the Hong Kong flu, et cetera, year after year. If this is going to be a virion that doesn't go back to its animal reservoir to kind of reformulate and make a new tough version of itself, then generally it will, kind of peter out. It will attenuate over time. The normal common cold doesn't have an animal reservoir unless we consider ourselves the animal. And so it's just going from person to person to person to person. And it can't, if it knocks you down too much, it's unsuccessful in passing to the next person. So the comparison I came up with is, I don't know if you have this experience, if you've used this word in South Africa, but we call it crowd surfing, where a singer, has 10,000 people in the audience, and he's singing away, and at some point he jumps into the audience. This is a kind of a popular thing pre 2020, and the fans, hold him up and they pass him around, and then they bring him back to the stage. Well, that's great. If your singer weighs like less than 200 pounds, that's awesome. If your singer were 500 pounds and jumps into the audience, it would go splat, and then he wouldn't get passed around. So the bigger, heavier, more powerful virons, like Ebola, I would say, is like a 500-pound singer. That jumps into the crowd, and everybody around there, mind you, has a horrible time. So when Ebola comes, it's like boom, it's like a crater. from an acid, meteor or something like that, and boom, big explosion, but it doesn't get passed around. In order to be passed around, you have to be light enough that you don't destroy the people carrying you. And I think Omicron is kind of the logical, in a sense, next step. And whatever I have to get back up on my Greek alphabet. And mind you, they're not really fair because they skip a few letters. But whatever the next one is after Omicron, again, it will probably become closer and closer to the common cold. And likely the coronaviruses we have right now, 1 out of 5 of common colds historically are coronavirus. And so if we look back, through the generations, thousands and tens of hundreds of thousands of years, likely some of the ones that we consider common colds, they might have been more powerful, like SARS-1 or SARS-2, but they wind up attenuating in order to just be passed from person to person, which is their success mode. So if we're going to keep having the thing around and not communicate with bats and pangolins on a regular basis, then it's going to, in my view, it's going to have to, self-attenuate, make into milder versions.
That's definitely the hope, and I think the example you use is a great example. I have no crystal ball. I'm not sure what's going to happen in our winter next year. We'll be expecting something to happen. What it will be, nobody knows. But I think for the rest of the world to take to heart is the fact that we're still under 30% vaccinated, and this is the mild version of whatever is going on that we have.
Exactly
so
right.
If you're highly vaccinated somewhere
That's
else,
an excellent point.
either you hope that is going to be the same for you, but there's no reason to panic because most of the world, including the US, you've done way better than us in terms of getting the population vaccinated. But this is what we are saying with the lower number. So I think that's actually a positive thing to look forward to. But it's definitely and hopefully, if you look at how, they say it's how many mutations, 35 mutations that they have on it. So you think that if you mount a response to that, it has to set you better for the whatever's coming up next in terms of being able to fight whatever's coming up next. It has to. That's what makes sense scientifically anyway. And I'm inclined to believe that. And especially if you look at the fact that even with the previous ones, which are not as people that have been exposed to the previous ones, definitely people that are Delta are not coming up in this wave with Omicron. So hopefully this will actually be the start of the end, and I hope it is.
All right, perfect. Well, thank you so much, Nathi. I very much appreciate your generosity and your time. Clearly, you had a long workday. I want everyone to know that it's middle of the day for me, but for Nathi, it's the end of the workday, and he's been a extremely generous and informative person for us and a great soul. So thank you so much. Any last words for our audience?
Thanks for having me over. It's been a pleasure. Glad I could share some information. For the audience is just stay strong, stay positive. When you do get ill, I speak to a lot of people. When it is bad, it does feel bad, maybe for a day or two. But definitely treatments work. Just make sure that you speak to people that know how to treat. And it will be just a bad flu for definitely the 90% or more of people. I think actually even higher than that.
All right, wonderful. Well, thank you so much. I hope you have a wonderful day, a wonderful evening, and a well-deserved rest.